I'm Dr. Demetrio J. Aguila III. I'm a peripheral nerve surgeon, I'm an ear, nose, and throat surgeon, and I'm also a plastic surgeon. I'm the host and founder of the Direct Care Movement podcast, where we dive into the intricacies of direct care, whether it's direct primary care or direct surgical care. You can find out more about what this movement is and where it's going and where it came from. I'm excited to have with us today our guest, Dr. Jeremiah Fleenor. He's an emergency physician here in Nebraska. Hello, Jeremiah.
Hello, good morning. Wonderful to be here.
Awesome. Let's start with you telling us a little bit about yourself. Tell us about your background and what you do today. Yeah. And a little side note, Grace, we can cut this one piece out. Let's try to avoid mentioning any specific companies or names of institutions, just so we don't have to worry about somebody saying, hey, you said this about us.
Yeah. Fantastic. Yes. Well, I was thinking about this in preparation for the interview. I've actually been involved on some level with healthcare for over 30 years, which makes me older than I originally thought I was. But started out in the Navy, actually, as a hospital corpsman, and so a medic, and just explored that. And it was a wonderful time. And then progressed on through college. And as I was doing that, was involved just doing phlebotomy and other sort of jobs in the hospital. And then that evolved and went into medical school and got through all that training and residency at Cook County in Chicago, did emergency medicine, and then have continued to practice emergency medicine here in Nebraska.
Sure. So you were at Cook County. So Were you George Clooney, or were you... were you one of those other guys, at Cook County?
I wish. No. I just was the regular guy trying to keep up with the craziness that was going on.
Sure. Well, I mean, Cook County's a lot like Boston City Hospital, where I trained, and
I did a month there actually.
Yeah, I loved it. It's very crazy.
Yeah, very crazy. Yeah.
So today, obviously, we have our audience is primarily medical students, residents, fellows. Of course, anybody else that's interested in this topic of direct care, but. How did you start to get interested in direct care?
That's a good question. I suppose it just was this relatively gradual, evolving understanding and appreciation of things that I didn't like, that didn't seem to be working, and problems, and then delving into, why is it this way? Why do we do it this way? And then you start to pull back the curtain and wow, there's a lot going on here, and it kind of just progresses down. And I guess the further I went, the less I liked what I was finding.
Sure.
And so then that forced me to either be clinically depressed or look for other ways of is this the only way, or is there something else? And then that's kind of where this journey started. And it was one of our conversations in the emergency department where you said, hey, do you know there's this other thing, there's another way, so to speak. And that then started me down the path.
Sure. So, that's really the key question, isn't it? You mentioned it. Why? And I think, I don't know if you've had a similar experience, but through much of my medical training, and even before that, very often when I would ask why, I'd be told, we don't have time for that, or some other version of, don't ask that question. Has that been your experience also?
I think so. And it's probably largely a function, I don't know, maybe there's multiple things, but I think people don't know. Patients ask me, well, how this go with insurance? And I can honestly say, I have no idea. And it's really true, because I don't know what kind of insurance you have, and I don't know how this is going to get billed, because it's 1,000 steps between it and that, what we're doing in that bill. And so I can say I really don't know. And I think that most people don't know. We don't receive much of that training, if any, while you're going through medical school or residency. And it's so convoluted and so complex that I think most people don't know. And when you don't know, and maybe you think you should know, you're gonna quite often behave more defensively and just say, well, I don't know, that's not what we're doing, that's not what we're focused on, let's get back to the task at hand, because it's potentially upsetting to you that you don't know.
Sure. So, and that's kind of ironic when you think about it. You go someplace like McDonald's and you say, okay, how much is the Happy Meal? The person at the counter knows right away, right? Or if you go to buy a house, you ask the real estate agent, well, how much is the house? It's not they're not going to say, oh, no, let's not focus on that. Right. Let's focus on the house itself. Somebody else is going to handle that. And you'll find out 6 months after you move into the house whether or not it's going to bankrupt you.
Right.
You know,
problem.
It is. It's a big problem.
The only thing I know of, or area that I know of, where that is kind of the practice. And it's fascinating, just like you say at McDonald's, or you go into a coffee shop and you say, how much is this cup of coffee? It's there on the board. And for medicine, that's not the case. And the question is, so you walk into any sort of establishment and it's how much does this cost? But when it's healthcare, you walk in and it's, will insurance cover this? And that's just fundamentally different, radically different. You could not have two more different models, because then your decisions are completely altered. And that changes the way healthcare is delivered and how healthcare is received. That fundamental difference.
Sure. So now tell us about, you mentioned some frustrations and roadblocks and things like that. Mm-hmm. Tell us a little bit, let's dive into that a little bit more. Mm-hmm. Tell us more about that.
Mm-hmm. It's interesting. Gosh, you could go a lot of different ways. I was listening to a podcast. There's a podcaster, or excuse me, a YouTuber this Ali Abdal, I think is his name. And so he is actually into productivity, is a lot of what he'll talk about. But he is from the UK and went to medical school there. And so it sounds like his motives might have been more might have been his parents or other people or things like that. So maybe you'd say he kind of started off maybe on a path that he wasn't as excited about. Regardless, as he's going through this, he's not liking it. And he's sort of conducting informal surveys with all those around him and saying, what do you think? What about this? And everyone he's talking about or talking to does not like the healthcare system, working in it. These are other docs and medical students, et cetera.
In the UK?
In the UK.
Okay.
And so as he, and they said, well, you got this other side hustle, this YouTube thing, you should go do that. You should go do that. And of those who even wanted to stay in medicine, and because they liked it, they certainly wanted less. And so the best he could find is, I'll take less. And so it's really interesting as I look at that, and you could say, well, that's a whole different country, but at the same time, that's really very similar to what I'm experiencing here. So I don't ever, when I kind of started off, it was a cool thing to be a doctor. People wanted to do that. That was something that was to go for. I mean, it's a really good thing. And now I don't hear anybody saying, yeah, go be a physician. It's go do something else. Sure. Try and avoid the healthcare field if you can. And so that kind of makes you sad, I guess, on some level. But at the same time, I would tend to agree that, man, unless you have a real strong calling, this is not exactly the most fun place to continue to do what you do. So there's that backdrop. And it was interesting to me that you could see that in other places, a similar system. I'm certain that's socialized, but still a Western mindset with regards to what that man was going through. And so I as I see now, even just in the 17 years as a physician, it's just trended towards higher volumes, increased cost, and lower quality of care. I just can see it. I can feel it in those that I interact with and what's expected of me by administration. And that just is a very challenging thing. And it's ubiquitous. You just talk to other docs. And even the thing I was talking to one of the guys that I work with, the particular things that we would do in emergency medicine that were kind of cool and, I don't know, a little bit more refined aspect of our specialty, like I just don't have time to do. I mean, I'm not sewing a nail bed anymore. Like no one does that. There's just not enough time for that. And so it's just changing and that dynamic. And so, I mean, there's a lot that could go into that, but those general things that I absolutely perceive, and I know it when I get my insurance bill, it's like renewal time right now, wow, this is how much I have to pay. And then I know what I'm going to get for that. And so costs go up. What I receive keeps going down personally. And then as I'm trying to deliver and work in this environment, I see quality decreasing, costs going up, volumes going up. And so that's just kind of an overarching collection of problems.
I find it fascinating. So you mentioned this physician in the UK who is experiencing a lot of these same concerns that we're experiencing here in the United States. Yeah. And yet, I've heard it said by many people that the solution to the problems we're facing here in the United States is a socialized medicine, single-payer system, just like the one in the UK. Mm-hmm. Well, based on this one person's experience, it sounds like that doesn't actually fix the problems that we have here in the United States. Is that your impression also?
Well, yeah.
At least the ones that we're talking about here.
So an increased push within the United States for a one-payer system. Yeah, I would gravitate away from that as a solution. And I think you can look abroad, and we wouldn't be the ones blazing the trail. So there are many, many examples. And I think if you can get honest and accurate assessments, then most people are not excited about that. I've known local people who have been in Canada for various reasons and had to go seek health care there. And it's a very different experience than what happens here in the United States. And so, in general, a lot of those things, painting with a very broad brushstroke, a lot of those systems, I think, tend to look very good on paper. And in practice, I don't think they deliver on what was anticipated.
Sure.
Yeah.
Yeah, I mean, I've heard that from many of my patients, many of whom are international, many of whom come from countries like the UK or Canada. And the underlying question is, well, if it's so awesome there, then why are you here seeing me?
Correct. And
I usually get a whole bunch of different answers, but most of which involve the shortcomings associated with those systems. So then let's dive into a little bit more. What do you see as the fundamental problems? What are the core questions that we're not addressing particularly well right now as a society, as a healthcare system, that eventually we're going to dive into some potential solutions today, right?
Yeah.
But what are those core concerns? What are the ones that frustrate you and make you say, you know what, it doesn't need to be this way?
Mm-hmm. Well, yeah, good question. I mean, there's certainly various aspects that you could focus on. I mean, and we sort of have hinted at that or even talked about it. If you uncouple cost and benefit, it will end in dysfunction. It just will. It just is the human nature. I mean, you have to know, and there has to be an appreciation of cost and then benefit, because then that's how you determine value. Like, there's no other way to do that. And then once you have that basic construct in place, then it helps facilitate personal responsibility, which is a key component for all parties involved. And so I don't know if that's in-depth enough, but you have to have that linkage, because then you don't know. And there are patients that come in and they're so genuine, and they tend to be, this category of patients tends to be fewer in number than others, but they're really concerned about cost. And they're like, what is this going to cost me? And it breaks my heart that I'm like, I have no idea. Like, this exact same workup could have at a minimum 5 different prices depending on insurance or not, or is that on and on. Like, that's hard for me. I would love to tell you, and I really appreciate that you want to focus on this and you care about this, but I can't do it. I really don't know it. And that's hard. It's hard for me. It's hard for them. And so there has to be that connection.
And it's unfair, isn't it?
Mm-hmm. Yeah.
It's unfair for them not to get those answers.
Yeah, because it matters.
It sure does.
Yeah.
Now, I've had a number of people raise the objection that healthcare is different. We shouldn't have to have discussions about cost because healthcare is a necessity. But when I have those conversations, I'll commonly bring up the 2 topics or the 2 areas that we just discussed: food and shelter. Mm-hmm. I would argue that for most people, under most circumstances, those are a much greater and immediate necessity than healthcare. Mm-hmm. And yet, most people would consider it unfair not to know cost in that scenario. So how would you, or when you have these discussions with friends, family, colleagues, how do you address that question when it comes up? We shouldn't have to think about cost. Healthcare should be completely disconnected from cost.
Mm-hmm. I mean, it's a good question. Even if that is to be true, it can't be. It just doesn't. I would love that. I would love a lot of things, but that just can't be. There must always be cost associated with benefit, because then that is the only way that value for both those who are providing the service and those who are receiving it. There's no way to know. That is a form of communication that's just necessary and inherent. And I mean, as you look at different economic models and things like that, and economic systems that various countries have tried, like that's the linchpin, I think, for all of it. So trying to answer your question specifically, I don't know if this gets at it, but I would love for it to be able to be completely provided, but in those areas, countries where that is the case, it still doesn't work. It's just still not enough. And so ultimately, maybe the answer is, because of the imperfection of humanity, things can only be so good. And so there's not another system out there that I have seen that delivers that which maybe we all would want. And so in light of that admitted shortcoming, then you go to your next best. And I think the next best then is direct pay, where you have the most proper linkage of cost and benefit. And that's as good as it will get. Sure. And that might be the answer. As much as I don't like it, or anyone else may not like it or wish it was something different, that might be as good as it gets.
So let's dig into that. So, in the direct care model, whether we're talking about direct primary care or direct specialty care, we've covered that particular question in various ways so far with other guests on this podcast. Where do you see the benefit in direct care in addressing the problem? So, we have problem X, and here's at least part of the solution. Mm-hmm. How do you see those fitting together?
So I think you could, answer that on a lot of different levels. And for me, because it is unique in that, I don't foresee me being able to fully practice emergency medicine, certainly in a direct pay model. And so you say, well, gosh, why are you even in this thing then? Well, because there's still tremendous value here. And for me, it's hope. So on a more overarching, in a more overarching way, just to have hope that it doesn't have to necessarily be the way it is. If you love the way it is, that's totally fine. Then you don't even need to entertain these other ideas. But if you don't like the way it is, there's something here, and it's real. And so I'm investigating something that is real, that I'm seeing working, and really it's a game changer for all parties involved. Like, I love when I find win-win situations. Those are the ones you like to invest in. And I'm not talking monetarily. I'm talking just with your person, your energy, all sorts of other resources that you have that you bring to the equation. So hope would be, I think, the number one, and encouragement that there's another way, and it's legitimate, it's gaining momentum, it has legs. And as I get to see how it transforms all parties involved, the lives of all parties involved, that's exciting. And so that then energizes me and brings me back to the emergency department, where you're slugging out another shift with all the challenges that you have, with a renewed sense of hope. And that's good for me. It's nutritive for me, but also then for the patients that I interact with, that, there's another thing. Even if I'm not able to provide it, perhaps I could direct them to someone and say, hey, if you're interested in this, there's a couple other things, a couple clinics in town here that run it differently. Oh, you can't get in to see your doctor? Oh, wow, it's going to be 2 months before you can even get in. Consider this, even if it's just a one-time thing. I've even done that, having insurance, and I'm like, I'm not even going through that route. That pathway is such a mess. I'm just going to go over here because I happen to know I can get the x-ray that I need for, $50.
Fraction.
Yeah. And so I'm even utilizing it. So I think that's one of the areas. What else would you say?
Well, let me ask you, because you just prompted a question in my mind. So what are some of the mechanisms that exist currently that stand as obstacles in the way of either having the conversation about direct care or finding the resources for direct care?
And I'm presuming you mean that just in general, not necessarily in the emergency department. Yeah.
Right. Or if you want to focus on, emergency medicine, obviously you've got a lot of experience with that. Mm-hmm. Certainly feel free to do so.
Well, is it probably not all the things that a new movement faces, education? It's just such a big, as I talk to various people who are interested in this topic and are in this field and pushing and working in this area, always it's education. And then the idea of needing to which is part of education, but change understanding, there's fears and misconceptions about really anything new. And this is special. While I still would hold the delivery of healthcare to, the economic model that I was talking about, it is special. This is your person. This is your health and that of your family. So it does hold an extra level of specialness. I can't think of another word. Importance. There we go. And so that does matter. And so people might be all the more reticent to accept something new when it's like, at least we've got this work and I don't like it, but at least I know how to get relatively reasonably from point A to point B. So I think I'm going to let it be.
The devil let you know.
Yeah, it's true. Is a little more tolerable than the one you don't. I think that's fair. So that's a big one. So education, and then just the genuine fear of change. And then you have interests that benefit from the system as it is and remaining as such. And that's always the case. That's not novel. And so whether they are willing to come on board with a new thing or whether you have to work around them, then is also something that has to be overcome. And that's a whole wealth of information there, what that might look like. But I don't know. Those are kind of three genuine or specific things that could be.
Now, you have a particular interest and an expertise in history. Have you finished your master's degree?
I did. I finished it.
Congratulations. Because I know that the last time we met, or maybe one of the previous times to that, you were getting close to finishing and you were really excited about it. So congratulations on that.
Thank you.
Now, help our audience understand how those studies, how your study of history have informed your perspectives on the problems in healthcare and the potential solutions. How do those fit together?
Yeah.
Because this isn't something just all of a sudden popped up.
Right. Yeah.
It got here somehow.
Correct. Yeah. So you could probably answer that question a lot of different ways. And I will tell you, I have not done a deep dive certainly into the historical aspect of a lot of how we've come to where we are with regards to healthcare. In my general understanding, and don't hold me to this, is, in World War II, there was some component of needing to augment the economy without changing pricing and things of that nature. And so it became this healthcare as a benefit, then became this entity where you could have a positive thing, a good that you didn't necessarily cost per se, right? So you're sort of shifting things. And then that has just kind of led us down this path. So I think that's interesting in and of itself. But to answer the question more specifically, I think it would be just principles in nature, right? And these are just going to tend to be more free market, capitalistic principles, and not bad capitalism. There's plenty of ways in which that has gone very negative and is perverse, but that doesn't mean that all capitalism is that way. So, and it's fascinating. I was looking into historically how welfare was dealt with, and there was grave concern for the neighbors and for the people in your town. That's the only way you made it, was by sticking together. And various towns, I was reading some of what the Puritans were doing in New England with regards to, they'd come together, whatever it was, periodically, once a week, once a month, and say, okay, here's the deal. This family is struggling with this, and this one is this and this, and we need to kind of pool resources to try and help with that. So I don't think by saying, if you adopt a more traditional capitalistic model for any of these sorts of things, that necessarily means you don't care about other people, that it is just about yourself. That is not true. And I think historically we have seen that people have cared for one another in this country. So I was reassured by that, because you see plenty of people who are just about themselves, and they, will do this under the banner of capitalism, and that's not good at all. So, historically, I think I take that away. I also kind of try to understand just in general, has it ever been worse than it is now? Just in general. And so it's nice to know that, hey, wow, there's been really hard things that our country has had to go through. Some of those are obvious, some of those are more subtle. And that then helps me as I look at this challenge. I'm like, whew, this is a lot, but hey, look, they've had to do this before, and here's some of the things that they did that were helpful, and maybe we can try some of those as we apply those principles to our unique set of circumstances here. So
Sure. Now, as an emergency physician, obviously you've been throughout your career acutely aware of the concerns relating to burnout. I remember as a medical student, and at that time, back in 19 emergency medicine was a relatively new field. It wasn't well established yet. There were only a handful of residencies in the country at the time. And since then, obviously, the field has really flourished and matured and come into its own. But I do remember at the time, and unless I'm mistaken, this conversation is still ongoing in emergency medicine, this concern about burnout, that, emergency physicians are much more likely to burn out and sooner than a lot of other specialties. But what I've noticed in talking to medical students and residents today is that that's not a conversation that's isolated to emergency medicine anymore. This is a conversation that almost every single person that I talk to now says, and so many people see medical school and then residency and then a career in medicine as a stepping stone to something else, as opposed to medicine being an end unto itself.
Yeah.
How do you see potentially that conversation shifting with the growth of direct care?
Well, I think it could be profound. Now, in the field of emergency medicine specifically, maybe not.
Sure.
But all of the clinicians that I've got to talk to and interact with that are active in the direct pay arena, they all seem to have a much more balanced life. And in fact, so many of them were like, I just can't do this over here anymore in this more traditional model. I cannot go further. And so I've almost been forced just out of necessity for whatever was producing that rate limiting step for them. So I think it is a solution, which is why I was saying, I really see win-win-win. When I look at this, these are the systems you get excited about. This is winning. The docs are better for it. The patients are better for it. The economy, and I just mean costs spent for things, are better for it. It's unbelievable. So I view it as a real solution. This is a real thing that can help. It's not that it's not hard. It's not that you don't work hard. It's not that you don't have bad days. It's none of that. But it is so much more of a balanced approach to life. And I think then you also start to get into some of those less measurable, less tangible, but all the more or sufficiently real aspects of purpose and contentment and things like that just add in significantly to your well-being on the whole.
So how does direct care facilitate those things? What are the specific things that you can point to? Again, keeping in mind who our primary audience is. At this point, if you've gotten this far, half an hour into this conversation, you're at least curious about the conversation. You're curious about the topic. So some of our listeners at this point are thinking, okay, this sounds great. How does it actually do this?
How does direct care
impact all those areas you just talked about?
Well, that's a good question. The things that come to mind is the parties that are involved, and we can just say that the clinician and the patient, both want to be there. They're paying for it. So that matters. Again, it's that cost and value. And so I guess it's proper alignment, more proper alignment. The clinician is providing a service. It's a craft of sorts. They know what they're offering, and they know it more. Like for me, again, emergency medicine may not be totally applicable, but I think just in principle could kind of hold. That's less of a craft for me because I don't know how much that thing costs, and I can't help guide the patient as to, listen, here's what I think the ultimate diagnosis is, and I bet you we could get there by doing do. It just is so much more rote down these paths, and you just kind of go. It's less craft than what I think my understanding thus far of what direct care is, and that matters because then there's so much more ownership. And not that I don't have ownership in my practice, but it's different. And so there'd be more ownership on the end of the clinician, and then there's more ownership by the patient. Wait, what is it you're going to provide, and how much does this cost me? And do you really think that that test is actually worth this amount? And if so, why? And then it's a dialogue. So you're building more relationship too. I think that matters and is very important. I'm trying to think if there are other ways and how that comes to be.
Well, you mentioned relationship.
Yeah.
In a conventional model, the relationship is between the physician, the insurance company,
right, yeah,
and the patient. How does that differ from a direct care model, and where's the upside in the direct care model versus the conventional model?
Yeah, boy, there's a lot of analogies you could use. We'll be careful with the ones we choose. It just is kind of a third party, and that always will add another dimension. I mean, if you add another gear in any sort of system, that introduces various things, and sometimes problem or, potential for problem or challenge is introduced. It just is. And so there's another entity in the mix. And so it's more complex at a minimum. And it then comes with all the things that we've talked about, where there is more confusion with regards to what payment will be and who's responsible for what. And it just misaligns motives. And that's a fundamental challenge. That's a fundamental flaw potentially. And so, that's what that does. So then if you say, okay, well, the direct care model, then it eliminates that additional entity, and it allows you then to just have what is more natural, but properly aligned motives and just a properly aligned system. Like I can have a vehicle, and let's say I have to push it. If I push it in the direction that the wheels are going, you know what I mean? It still is work, but I'm pushing it more in line with the way it should be. I could push it by rolling it over on its end, but that's not the way it's supposed to be. That's misaligned. Do the thing that is more proper, more natural, and it will work better. So I just view, it's maybe an odd example, but having that additional entity in the middle is not as in line with the way the thing is designed to work, and therefore it's more challenging and introduces more complexities.
Sure. So I want to change gears just a little bit here, and I want to talk about something that I know you've got a lot of ideas about. As you and I have had these conversations about direct care, you've started to give yourself permission to think about things that maybe you hadn't given yourself permission to think about before. And I'll phrase the question probably in a way that you haven't thought about in this way before, but hopefully it'll lead nicely into what I hope you'll share with us. In an ideal world, if you were king, how would you revamp the way that emergency care is delivered? I know you got a bunch of ideas about this. Where do you see the holes or the shortcomings of our current system, and what are some of the ideas you see? And I know this isn't a fully developed idea yet, but you've got some fascinating, innovative thoughts on this, and if you're open to it, I'd love for you to share them with us.
It's interesting. I think particular to emergency medicine, there's always that component of emergency where just time is of the essence. And because of that, so many other things cannot come to the forefront. And so there is that inherent challenge with this specialty in particular. And yet, a small percentage of what I do on a daily basis are emergencies, right? Or
true emergencies.
Cases, right? Cases that fall under that rubric of just time is of the absolute essence. And so I guess having that very large caveat in place, personal responsibility, I think, is a huge component for all of us, across the board, and how things are utilized. And so, and you see it, though, it's kind of a manifestation of the challenge of the system, because it has largely become convenience care, because you're there, 24/7. It's so hard to get in anywhere else. There is, no payment required up front. I literally have had patients say to me, I would have gone to urgent care, but they require that I pay something. So I'm coming to you guys because I know that I can come in and, and even if it's brought to their attention, this might be upwards of 6 times more expensive than that. It doesn't matter, because that happens down the road, And so I guess if you're hurting and, man, your tooth is killing you, that's awful. I will still choose that. And so, I can understand how that comes to be. So the idea of like personal responsibility, and I think is something that would have to change. And how do you instill that? I don't know. I was thinking, even if, I mean, this is some pretty macro stuff, but you could almost even keep the system that is in place. If society just said, you know what, let's transition, and we're going to go to a more, we're going to try and go away from what we're dealing with now and go to something else. And I think Ben Carson had even commented on this with regards to same amount of money allotted per person for healthcare, but then it's fixed. And so it's then you have personal responsibility to say, I have this amount of money this year for my healthcare, and so I'm going to have to think through this, et cetera. And I mean, obviously you come to so many patients that just wouldn't be able to do that, whether there be mental illness and all sorts of stuff. So it's not perfect, but for a large number of people, I mean, that is something then that could be, and it's, nothing has changed. It's still the same amount of money per person, but it's, maybe trying to help educate with okay, here's how the system works, and here's different pricing. Because you would almost say, well, wait, this hospital actually does have a different cost for their MRI as opposed to this clinic next door that's an outpatient MRI. I'll have more of my money left, and so I think I will go here. And then there's that, not only the personal responsibility, but then the personal investment. And it's more, right? Like my dad said, I'm not buying you a car when you turn 16. I will help you get it, and I will show you how to take care of it, and I'll help you get insurance and all that stuff, but I'm not buying it for you. And so I had to go and do all that, and it meant more to me. And so I think that is a component of it too. I don't know, just those two things alone, I think would be hugely important. And then more of an acceptance and an opening up about price, which there are strong powers that don't really want that to be, but I think that's important, and bring that in. Like, so many people just almost think it gets paid with by monopoly money, and it doesn't. And there's real cost with this, and that just really matters for everybody. And it's not wrong to talk about cost. And I think it's an important part of it, because of it just helps in so many ways to understand how things are costing and how this works. So I don't know if that's a lot or enough, but those are some things that come to mind.
Sure. Well, as we wrap up here, I want to ask you the most important question, the key question that I think just about every single one of our listeners wants to hear your perspective on. What do you know now, as it pertains to direct care, that you wish you had known when you were a medical student or a resident, way back when, that might have altered your perspective or your trajectory?
Good question. I mean, for specialty purposes, I don't know that it would have altered that per se. I could see for some how it really would. There's two things that come to mind. The first of which is I just wish I knew then what I know now with regards to how the system works. It was just so big and overwhelming, and medicine is hard. There's a lot to learn, so I just was trying to keep up with that and learn to be a good doctor. That's a good thing to learn. And so that's what it should be the primary focus. And so it was all so big, and that was plenty big enough that then to focus on how the system worked was just a bridge too far. I just couldn't pull all that off. And so maybe even just the capacity to then appreciate that, and then now have the understanding that I do, which is limited, but more than then, of how the system works, because that matters. I mean, the gears and the wheels are moving for a particular reason, and they want you to stand here as opposed to there because of this system. And so to understand it and where you fit in it, I think is really important, even if nothing changes, just for your own peace of mind. Here's how this works. This claim goes here, and this person deals with it, and it goes to that entity, and then they go there. I mean, it's worth knowing that. So I wish I knew that. But then also, maybe I wish I would have come to this sooner, the idea of what's going on with the free
market medical.
Free market medical and the direct pay. It provides hope for me, and that matters because, and I don't know how many listeners feel this way, but it's really easy to get discouraged, and I think it's getting easier to get discouraged and overwhelmed and disillusioned, and those are not three things you want to be thinking about as you're trying to learn and how to become a doctor, and did I even make the right choice? So to know that there is something that's very legitimate that is out there that is helping people and helping clinicians and rejuvenating some of the docs that I know you and I have got to meet and talk with. They're rejuvenated when they get to do this. I mean, that's that's amazing. That's special. That's powerful. And so I guess I wish I knew that before. Even though I don't practice the direct care model, it helps me when I get to talk with you and I'm like, look what he's doing. This is amazing. And I bring that back. And so that hope and the idea that there is really something better and it's real and it's working, and that even peripherally as I'm involved, it's amazing. And so being involved even more directly could be all the more amazing.
Well, that's exciting. I mean, you're a very active member of our chapter of the Free Market Medical Association here in Nebraska. And one of the things that I think I probably neglected to mention in our previous episodes is that over the past few years, the FMMA has made it its goal to have a lot of medical students attend the conference at no cost to the medical students. Cool. This last year, there were 85 medical students that came to the annual conference, which is usually in April or May, at no cost to them. It was sponsored by members of the FMMA. And the goal eventually is for there to be more medical students at the conference than there are physicians.
That'd be wonderful.
And, we're moving in that direction. And it's exciting.
Isn't there and you may know this, and in fact, I learned it at that Kansas City FMMA conference. Isn't it like Benjamin Rush Society?
Yes, they've been sponsoring a huge part of this.
For medical students.
Yes, specifically for medical students. But there are others. There are other sponsors who have also who have taken up that that mission to make it possible for medical students. I know that Dr. Smith's goal and Jay Kempton's goal is for every medical student in the country to be able to attend one of these conferences at some point before they graduate from medical school.
Yeah. And even if you don't fully espouse this model or won't be practicing indirect care, to know that it's there.
Right.
I mean, because you want to do what's best for your patients. You want to be able to offer them things. And so, okay, it's not working here. Hey, have you tried this? Even if it's a one-off, try this.
Exactly. Exactly. Any last thoughts? Any other things you want to cover or share?
I don't think so.
All
Thank
right.
you.
Well, thank you for being with us here today. It was
Pleasure.
exciting having you on board. And I love hearing the perspective of somebody in emergency medicine who sees the downstream effects of direct care. And it's exciting to hear that. And hopefully it's exciting for our listeners. Thank you for joining us on the Direct Care Movement podcast. We're excited that you joined us, and we're looking forward to having you join us in future episodes as we dive into more questions and more concerns and more solutions in the direct care space, whether it's direct primary care or direct specialty care. If you liked what you heard and you want to know more, please click like and subscribe and leave us a review. And don't be afraid to reach out to us directly so we can get you more information about direct care, whether it's direct primary care or direct specialty care.